Okay, welcome everyone to our webinar sponsored by the Setting Scoliosis Straight Foundation, entitled Vertebral Body Tethering versus Posterior Spinal Fusion. On behalf of myself, Amir Samdani, and my co-moderator, Josh Murphy, we welcome you to this webinar, which will be a fantastic opportunity to share the latest research and clinical practices. We are very lucky to have four phenomenal speakers who are very experienced in both spinal fusion and vertebral body tethering to share their experiences and teach us about the latest of what their clinical practice and what they've learned over the years on both of these fronts. But the highlight of our evening is sure to be our guest patient speakers. A big thank you to Amanda and Allie, who will be speaking about Amanda with respect to her experience with spinal fusion, and Allie with respect to vertebral body tethering. So we're really looking forward to both of your talks, and a big thank you. Of course, this webinar is for you, so feel free to submit all your questions through our Zoom Q&A section. After each talk, we will have a Q&A seminar of questions, and we will, during that time, try to get to as many questions as we can. And the ones that we don't get to, we'll be able to write a written response, at least to get you some feedback on your question. We're going to start out by talking about the pros and cons of VBT versus fusion, then jump into what's the latest research in vertebral body tethering. And then, of course, we want to make sure we give you a good appreciation of what you find online versus what that research entails, and talk about the access to VBT and online myth busting. And there are some patients that may benefit from both a combination of fusion and tethering, and Dr. Newton will educate us on this hybrid procedure. Then, as I stated earlier, Amanda will tell us her story on posterior spinal fusion, and then Allie will give her story on vertebral body tethering, and then my co-moderator, Dr. Murphy, will have some concluding remarks. Before we get started, just a word on our Setting Scoliosis Straight Foundation. We are a nonprofit 501c, established in 2018, and our mission is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide, with our vision being we want to see a future where children with scoliosis have the ability to live healthy, happy, and productive lives. And with that, I'd like to introduce our first speaker, Dr. Firoz Miyanji, who's going to educate us on pros and cons of VBT versus fusion.
So as Amr said, my name is Firoz Miyanji, and I'll be talking about pros and cons of tethering and fusion. I think it's important just to dial back a little bit and look at the principles of scoliosis surgery. First and foremost, any treatment for scoliosis is really to prevent the progression of the curve. We ideally want to do this through a single surgical event and then get a balanced correction of the spine. We want to improve the rib hump, the waist and shoulder asymmetry, and try and restore the natural curves of the spine, both from the front as well as from the side. Now, spinal fusion, of course, using rigid rods to try and obtain these goals has been the long-standing gold standard. But now with VBT, it's probably the first time that another surgical procedure can be considered. No longer do we think that spinal fusion is the only option in the space of idiopathic scoliosis. And I think more and more as surgeons and the surgeon community, we've really learned a lot, at least I've learned a lot about patient autonomy and the concept of a shared decision-making model. This really becoming increasingly the focus around discussions when patients are looking at either VBT or spinal fusion. Again, fusion, we really feel that it is a good procedure, but up until now, it's really been compared to itself because there's really no other option. We do collect health-related outcome measures, primarily the SRS-22. These are patient-reported, and generally we have very good reported outcomes, but when you really slice it down, these are surgeon-developed. We're actually asking the questions to many and all of our patients in terms of what's important to them after they have a fusion procedure and how they're feeling. But if you really look at it, many patients may say that they can't slouch, they're always upright, they complain of upper back stiffness. But the fusion's been around for a long time, so it does have a track record of obtaining the goals that I just initially outlined. There's really no upper limit of curve magnitude, so the indications are rather concrete. curves over 50 degrees. We know that the natural history is one of progression. So to prevent that, we offer a fusion for a magnitude of 50 or more. And of course, the cosmetic result is predictable, and you can obtain this immediately. But it is considered fairly invasive. We instrument the spine. We will then do osteotomies, where we eliminate connections between the vertebrae so we can manipulate the spinal column. And then we have to put down a bunch of bone grafts so that that column fuses together, and it doesn't allow that deformity either to come back. And hopefully we get a nice balance correction in all the planes we're looking for. But again, the correction is rather immediate. What you get immediately in the operating room is where you will be and where you will stand for the rest of your life, essentially, when the fusion does take. And the chance of requiring further surgery, it is not zero, but it is considered low. Generally, most of the reports have been anywhere from 5 to 13%. But again, it's considered a one and done procedure with predictable result and predictable long-term result. When we return to activity, at our center, a minimum 6 months so that fusion can mature and take. Some centers that are conservative may extend this to a year, but the point is you can return. This is one of my patients who was a model for the original Google Pixel phone. This is following her fusion surgery. And over time, this is about 10 years later after her fusion surgery, she generally sends me an email how she's doing and how life is progressing, having a thoracic fusion. And more recently, she's become a firefighter with the interior of BC. So of course, even after a fusion surgery, life goes on, and you can certainly do what you would like to. But there's no question that fusion is at the expense of motion. See, this is some of some data on some studies that we've been doing, looking at patients that have been fused as well as had a VBT procedure, and looking at intersegmental motion. And just looking at these X-rays, you can see that when you have a fusion, you're certainly not moving as much as you are in VBT. And when you extend this fusion into the lumbar spine, we do have decent literature and good long-term data that this may have some implications, especially into your adulthood. So, we don't take the fusion lightly. I think we do it, of course, when we need to, and trying to prevent that progression of the curvature. Of course, you are patients and families, as well as a surgeon network. We all believe that motion is important. We've certainly done this in areas of joint replacements for arthritis, et cetera. And of course, we always have believed that fusion is not the end all and be all, but motion around even the spinal column is extremely important. And that was really the impetus for some of the basic science models of non-fusion technologies. And the first reported clinical proof of concept was way back in 2010, where an 8-year-old male had an anterior tether placed and then showed some correction over time. And again, the impetus here really is to preserve motion and prevent and not have a fusion. When you look at VBT in comparison to a fusion, in the thoracic spine, we can do this through a thoracoscopic approach. So the procedure is, in my opinion, less invasive. The incisions are a little smaller. There's a little bit more direct exposure, and you don't really have to do much bony work and lay down bone grafting. So the overall procedure, in my opinion, is less invasive than a standard fusion. The correction, however, is gradual because we're trying to harness the available growth left in the spinal column to try and get that balance correction of the spine and all the planes. But this will happen over time as the patient grows. Return to activities is sooner. Many centers will be anywhere from 6 to 10 weeks on average, and some conservative centers may push it out to 3 months. But in my opinion, it certainly is a lot sooner than it is for a fusion procedure. Does it preserve growth? Well, we've looked at this through a number of registries, and we have noted that even in the instrumented areas of the spine following a tether, that area does seem to grow, especially if the patients are skeletally quite immature. You can have a range of growth anywhere from 12 to 18 millimeters, which goes to show that the VBT is doing that. Now, the impetus for where it was started in terms of motion preservation, we've done some work at Children's. Michelle Marks, the executive director of the Setting Scoliosis Straight Foundation, has done some tremendous amount of work around motion, both in the fusion patients as well as VBT patients. And we've noted that in certain motions, it appears overall that the patients that have a fusion as well as a VBT seem to be relatively the same, but it's really when you look at the overall motion. So in a VBT, the overall motions between your vertebral segments is actually well preserved, whereas a fusion, you seem to accommodate through areas where you haven't fused. And again, Michelle Marks and Dr. Newton was a primary investigator on this study. It was nominated for a Hibbs Award at a recent Scoliosis Research Society meeting, which is the highest award that you could be nominated for. And again, showed very similarly that the motion loss in VBT is certainly less than that of PSF or posterior spinal fusion. And in particular, in the uninstrumented areas, the spinal fusion patients seem to be moving a little bit more because they need to accommodate through areas where they haven't fused for the loss of motion in the areas that they have been fused. Now, we have to balance this, though, because the chance of requiring further surgery in a VBT procedure is significantly higher. The earlier studies have reported anywhere up to about 47% of a revision procedure following a VBT. And really, the concerns primarily have been around overcorrection or tether failure, where you may see some splaying of the screws and the deformity can progress, and you might need another procedure done. So we've learned that the extremes of skeletal maturity as well as magnitude should be avoided. If you're too small and if you're too young and have too small of a curve, then you can overcorrect. And if you're much older and your curve is very large and stiff, then the tether can fail. So it might be too effective and or not effective enough. And to that end, it's really raised the question of when is the ideal timing for the intervention? Really, how big or small of a curve can we treat, and how young or old should you be? And do we have a sweet spot where we can identify patients to try and provide this technology for them? For that, of course, we need large data so that we can show the impact of some of these new technologies, specifically in our clinical trials, and so that you can offer these advancements to a larger cohort of patients and hopefully everyone. The Setting Scoliosis Straight Foundation and the Harm Study Group has done a great job in setting up patient registries. So we collect anonymous data from multiple sources, and we try and use this data to answer difficult questions. And we live in a world of data, and we understand the importance of data, especially to predict anything from what you buy and what you like to shop online. And so in 2019, after the FDA approval of VBT in the US, we were able to set up two studies. One's a retrospective, so looking at patients that were done with this technology before 2019 and other patients that going forward after 2019, we collect them prospectively, so it helps us answer some of these questions. We have noted that the complications by collecting data like this have been dropping over time in VBT. In a cohort of 328 patients, we showed a complication rate down to 22%, and in the fusions, again, is not benign. It's about 7% at 10 years. But nonetheless, fusion patients will have a lower rate of reoperation than our VBT patients. In decision making, I think for non-fusion, when you're talking to surgeons and healthcare workers, you should expect more discussions on the timing, the curve size, the skeletal maturity. So really, are you a candidate? And as a patient and family, really, you have to understand that you might need an appetite for more surgery potentially. Around fusion, the discussion, of course, is a lot more concrete, a certain curve magnitude. You'll have a predictable cosmetic result, but it's not that you have no risk of a reoperation, but you certainly have a lower risk of a reoperation than VBT. But I say in 2024, VBT, provided the other elements of your curve size, its flexibility, and your skeletal age, it can be an option and maybe a point of discussion with your surgeons. So in summary, I think if you're really looking for a predictable cosmetic result, primarily a single surgical event, then fusion is probably the way to go. But if you like to preserve motion and get an earlier return to activity, albeit a higher revision rate, the non-fusion is something you might want to consider. And so I'd summarize that. Remember that all treatments are really to prevent the curve from progressing. You're not trying to get correction as your primary goal, and fusion is not the sole surgical option. And the landscape, of course, has really evolved to a shared decision-making model. I think fusion really for larger, stiffer curves in more mature patients, and of course, VBT and smaller flexible curves that have growth. You can use this technology as a viable option for motion preservation. In my practice over 10 years, really I've settled between about 25 to 30% that we would maybe consider a VBT. And so of course, fusions are much more readily done in my practice. Thank you very much.
That was great, Firoz. Thank you. So we have had, as expected, we've had some good questions come through. Some of them we've been able to answer and type. And then we've got a few more here. And I think one of the common themes coming up is about what's your ideal patient in terms of timing and skeletal maturity, curve magnitude for vertebral body tethering.
Yeah, so for a thoracic curve, for me, 50, 60 degree curve that's flexible down to less than 30. So it's not really a percentage, but a magnitude. For skeletal maturity, I use everything. I use the Risser, the Sanders, the patient's height in relation to a mom and dad. And of course, for females, provided they're premenarchal. So ideally a Sanders 3A, flexible, 55 or 50 to 60 degree curve, bending down less than 30 degrees, I think would be ideal. And again, the side X-ray, the sagittal profile, really should also be favorable for this. So you don't want too much of what we call hypokyphosis or lordosis through the anterior aspect of your spine. I think that's not an ideal patient for VBT.
Very good. I think in a little time, we're going to kind of keep things moving. I'd like to introduce thanks, Firoz. I'd like to introduce our next speaker, Noelle Larson from Mayo Clinic. She's very intelligent, caring, excellent surgeon. And she's going to talk to us a little bit about the summary of the most impactful and latest VBT research.
Thank you so much, Dr. Murphy, and really my pleasure to be here tonight. And I hope we have time to answer everyone's questions and have a great discussion. So we're off to a great start with Dr. Miyanji. And we heard a little bit about scoliosis, and really we're talking about idiopathic scoliosis, meaning there's not other medical conditions associated with it. And the type of curves we're thinking about for tethering are fairly uncommon, maybe 1 in 3,000 or 1 in 5,000 people. And there's all different kinds of scoliosis, but again, idiopathic is the one that is approved for vertebral body tethering, meaning it's not associated with other medical conditions. Fusion's been around for a long time. We think fusion is safe for pretty much any child over age 10, with curves that are typically over 50 degrees. And people do well with fusion, as we heard from Dr. Miyanji. So what do we know? We're now a full 5 years out from the US FDA approval, which is a limited FDA approval for vertebral body tethering. And there's 2 devices now available on the market. There's post-approval studies for both, and Setting Scoliosis Straight, is hosting one of the VBT post-approval studies. But we got to keep trying new things, right? We don't want to be doing the same thing 30 years ago that we're doing today. And although we're seeing kind of some higher, rates of a second surgery with VBT, we have to keep innovating, and we have to keep engaging in the highest quality of published evidence. And I think one of the shames is that as not having had 10 years of training in orthopedic surgery, it's hard to access the highest quality published evidence because it's often in these very thick journals and it's hard to understand. There's some basic facts, and I think people sometimes make kind of an emotional decision, like the fusion rod doesn't move and the tether rod or the tether cord is highly mobile. So, sometimes it's an emotional component, but what we really want to do is bring it back to reason and bring you some data so you can help make an informed decision for yourselves. The FDA has given us indications, and generally we're looking at curves over 40 degrees, generally looking at patients who have at least a year or more of growth remaining. And all this is kind of nicely outlined on the FDA website. And we see some great results with VBT, but we also see some results that give us pause. Like this patient looked amazing at 1 year, but now at 5 years, we've seen some cord breakage and a little loss of correction. Overall, still a very nice result, but with any new technology, we have more limited follow-up than with the established fusion. But again, we're going to talk a little bit about truth and research and the studies that this group, Setting Scoliosis Straight Foundation, has done and help you decide what might be best for your child. Our team here today, as well as the FDA and Dr. Lahner, just finished a very big 5-year FDA study where we were trying to make a shared decision tool. And part of that actually is an evidence-based guide for you to help decide, again, what's best for you. The 4 areas we decided to focus on for our evidence-based tool was correction or straightening, chance of a second surgery, spinal motion, and then recovery time. And I don't think this is quite live yet, but it's coming out soon with kind of a big review from many physicians, many surgeons that do tether and fusion about how do we sum up the literature for VBT. So as far as straightening, this is a study done by Dr. Newton and setting scoliosis straight. And basically we had 237 patients who had VBT compared to 237 patients who had tether. And basically we saw less correction at every time point with VBT on average compared to tether. This is kind of what the summative graph looks like. So less correction at every time point. We did a little study at Mayo. We had found the same thing. So it certainly has been replicated. And this is kind of our cartoon that we put together to summarize this. That again, on average, we're seeing about 50% correction of the curve with VBT compared to 65% correction with the fusion. Next point, risk of needing a second surgery. Dr. Miyanji talked about this a little bit, but again, in this study, we found 16% of patients that had a tether had a second surgery compared to 2%, and this is at about 3-year follow-up, 2% of the fusion patients. Now, as you follow the fusion patients out longer and longer, it may be that more of them will need surgery, but at least in the short-term outcomes, more chance of a second surgery with the tether. And here's our little graphic showing this. And why is this? Well, it's a little plastic cord like I showed you before, and a little plastic cord is just not going to do as good a job as 2 heavy-duty solid metal rods. So this child, we tethered one curve, the second curve got worse, the second curve got worse, and then we went ahead and tethered the second curve, so 2 surgeries, right? This child, we did a tether, she grew a bunch, she started to shift to the left, we released the cord, we got her back to midline, you know, it was overnight in the hospital, it was quick surgery, but still 2 surgeries instead of 1. This is one of the things that we see more commonly with tether. And then there's times where we just take on too much. This is a big curve, we didn't get good correction, curve got worse, and we ended up doing a fusion. And I guess I've learned in my practice, if you're gonna do a fusion, just don't wait too long, right? Because you end up necessarily fusing more of the spine than if you had just gone ahead and done the fusion, you know, a year or 2 years prior. But we do see some great results. The correction over time following the tether, at least in my hands, is relatively modest. Here's another great result, 9-year-old tether, 5 years out, you know, nice result. But it's not every single one. So I think that's why we as a group are working really hard to figure out the indications, figure out the technique, and make sure that we have a reliable product for you where we'll lower that reoperation rate. Because I think long-term 15% reoperation rate, that doesn't sound like a good long-term strategy. Okay, point 3, flexibility in motion. Dr. Miyanji showed some great data. We have some other data as well, just showing that there is flexibility, there is mobility after VBT. Again, this is kind of Mayo data, but Dr. Miyanji and Michelle Marks have very similar data showing that there's preserved motion more in the lumbar compared to the thoracic, and that the spine doesn't go on to autofuse after VBT. It's unclear what that actually means, you know, as far as function. We haven't shown a functional difference for particularly a thoracic fusion compared to a thoracic tether. I think we all pretty much agree that there's better function for a lumbar tether compared to a lumbar fusion, a lumbar being the lower back. And then point 4 was recovery time. And again, we see for the most part, patients are cleared at 6 weeks to go back to sports after tether. And for fusion, it's usually more like 3 to 6 months. So compare and contrast. And again, we have some cartoons and hopefully this tool that you can use with your surgeon or with your physician to talk through all these different points. I would say this is a very fast-moving field. We're going to have soon data coming out from the post-approval study, which was required by the FDA and is housed at Setting Scoliosis Straight. And I think there's a lot of room, again, for process improvement. Like looking back, there's stuff I would have done differently in 2015 or 2018. How much can we capture that knowledge and make sure we've made the surgery more reliable? Certainly as a group, we're all committed to try and have shorter operative time, shorter blood loss, shorter time in the hospital, both for the tether and the fusion. And we're working together to try and study these things. Our group feels that we have to get good correction on the table to have good results long term. So we're kind of going for more correction and maybe that second surgery for overcorrection in younger kids. But if we look at really a narrow cohort of patients, you know, that we get correction to less than 20 degrees, first direct is less than 35, we're seeing a higher success rate, more than that. 15% reoperation rate. So I'm just going to keep going. But here's kind of our team from the FDA that we've been working with, myself, Dr. Lana, now for 5 years. We have a nice paper talking about it. And we asked a bunch of families that were kind of struggling with tether versus fusion and trying to decide what they wanted to do. And basically, families really cared a lot about appearance, about that correction piece, and families really cared a lot about motion. And so I think the values may differ based on your family. And then I think your specific values at this time point are going to help you decide what surgery is best for your child. Please take into account all this evidence, and we're trying to develop more every year and every month and every meeting for you. And I think this teamwork of researchers and patients and physicians all working together, I mean, it's a real powerful combination. So please keep coming to our meetings, and we really look forward to making scoliosis treatment better in the future.
Thank you, Noelle, and both of you, just spectacular talks. I'm so glad to see our participants posting a lot of questions, and we're trying to answer as many of them as we can. We've got time for one quick question here, Noelle. So we have a lot of patients and their family members in the audience tonight. There's a lot of articles out there that are, supposed research articles. What kind of characteristics would you advise our patients and patient family members to look for in a research article where you say, these results can be reproducible and results that you can rely on? What are some attributes?
Our world kind of centers around peer review. So if we're going to write an article, we write a paper, we send it into a journal, and often they have 4 or 5 other surgeons, potentially from all over the world, that read that paper, and they try and poke holes in it. And then we write back to them, and it's kind of like a 6 to 9 month process to get something published in the medical literature in a high quality journal. And all the people on this panel tonight, this is what we do day in and night, weekends and evenings. Like, we write papers, we try to share knowledge. And that's different than some places where they're not collecting their data. They're just giving you anecdotes. They're giving you a patient story, which is super compelling, but it's much more powerful actually to have the summative data of 3 or 200 or 150 patients followed over time. So we're looking for time to follow up, level of scientific rigor, and then also number of centers that are involved.
Yeah, I think it's a great answer, especially the follow-up piece. That is so critical in everything that we do. All right, with that great job, Noelle, we will move on to our next talk. Will be from Dr. Jaysson Brooks, who's going to talk to us about access to VBT and online myth busting. Go ahead, Jaysson.
So I want to thank the moderators for inviting me, and I wanted to. I was asked to talk about VBT kind of from a different viewpoint. We live in an interesting time where you actually don't need us as doctors to actually get your information. No longer is information relegated to our textbooks. It's all over the internet. And that can become, that's great for dissemination of knowledge, but also sometimes it could contribute to, lots of myths being kind of shared regarding things that are otherwise well known kind of in the medical community. So want to kind of get into that a little bit as relates to VBT, and then talk about some other topics with regards to access to care. And so I think it's important to understand who your audience is, but I want to turn the lens on us as surgeons. There is an interesting study done in 2022 where they actually surveyed over 1,200 pediatric orthopedic surgeons on the social media platforms that they used. And what they found was that, first off, 47% of these orthopedic surgeons never even use social media. So I'll just kind of say that. And then for those that did use social media, only 2.8% had a professional Facebook account, 1.2% had a professional Instagram account, and 0% used TikTok. And so it's important to kind of understand that, because when it comes to our patients, or sometimes the patients, the parents of our patients, their usage is quite different. And so when it comes to the average age of current users for these different platforms, really it's now our grandparents who potentially are utilizing Facebook at a higher rate. Twitter, a slightly younger population. Instagram, it gets even younger, between 18 and 34 years old. And then in my anecdotal evidence, a lot of my patients are on TikTok, or some of my patients' mothers and fathers are on TikTok. And so there's definitely a mismatch between the social media usage and platforms, or the surgeons who are offering these various techniques, and the platforms that are actually being used by our patients and sometimes their parents. Just diving into Facebook a little bit, I think as physicians, we've all heard of these, what we call quote unquote Facebook mom groups. And when it comes to VBT, if you do a quick search, there are actually quite a bit of Facebook groups that are focused on VBT. Many of them with lots of members. The biggest one has over 11,000 members and has 7 posts a day. This one is private, meaning that no physicians can actually join. It's families sharing experiences with families. And then there are hosts of others with memberships boasting anywhere between 600 members up to 2,000 members. And so clearly information is being shared in these platforms. But again, it's families sharing experiences with families. And so there aren't really any referees that are able to determine whether things that are being shared are on par with what the medical literature shows. There is an interesting study that was also recently done by our colleagues out of Vanderbilt, where they actually wanted to look at, or kind of categorize, the type of information being shared online. And they looked at a number on online public forums, and they ended up settling on Curvy Girls and the National Scoliosis Foundation. And the themes that they were able to bring out of this was that, as you can see kind of in this this chart all the way to the left here, is that the majority of posters who are posting on these online forums, the things they were posting on, it was really related to the emotional aspects of dealing with scoliosis. And so, they were able to kind of show in this study that really the majority of reasons why families go on the internet to share their scoliosis experiences is to get that emotional support. And sometimes that's something that your physician can't offer. And also, very reassuringly, they also found a very low rate of misinformation shared on at least those 2 platforms. When it comes to misinformation, I've actually been very interested in looking at this, given that most of my patients are on TikTok. And so we did another study, yet to be published, where we actually looked at these various scoliosis hashtags. And we searched for these hashtags on TikTok. And what we found is, when it came to videos related to scoliosis, the average number of likes was 156,000. And the average number of views was 2.4 million. For videos related to scoliosis, the majority of them, over 70% of these videos, were patients describing their own scoliosis experience. This patient on the TikTok is actually one of the most followed patients who has had a tether. And she really shares her experience and has been a support for lots of people. So again, 72% of these videos were patients describing their own experience with scoliosis. For videos that were created by healthcare providers, the majority of the healthcare providers that are actually posting videos were actually not surgeons, they were chiropractors. And this was followed by non-surgeon medical doctors, and then the rest were nurses, surgical techs, etc. When it came to the quality of these videos, we used an objective grading scale in order to measure the quality of these videos, with 5 being the highest quality. You can see very few of them reached 5. However, the videos that were created by physicians ended up getting the closest to at least a score of 4, versus you can see the other categories that did not score very highly. We found that 44% of the videos that shared a healthcare advice on TikTok related to scoliosis contained misinformation. And kind of unfortunately, the videos that had information ended up getting more likes than the videos that did not have misinformation. And so that kind of contributed to more misinformation being shared. And so I think when it comes to overall online information, nothing replaces that doctor-patient relationship. And I think when it comes to getting that final data, you got to talk to your doctor. But when you aren't able to, I think going to gold standard data centers like Set in Scoliosis Straight, as well as OrthoKids, which is hosted by the Pediatric Orthopedic Society of North America, that'll give you some other gold standard references when you're not able to talk to your physician. And so that's looking at some of the potential misinformation that's on the internet. But how about access? And, many times, at least anecdotally, when I've been talking to families who want a tether, a lot of those families are flying in to see me in Dallas. And, it takes a certain amount of socioeconomic status in order to do that for a doctor's visit. And it did make us ask the question, is vertebral body tethering, is it accessible for everyone? Not just the people that can fly in to see a doctor, but those who might live right down the street. And so within the harm study group, we actually queried all the tethers in our database, and we compared it to a database of patients who had fusions. And in order to kind of grade the socioeconomic status of the patients who had received tethers versus fusions, we used a validated instrument called the Area Deprivation Index, which basically you have to plug in someone's entire address, and then it spits out a number that tells you where they are on the socioeconomic scale. And just for reference, if you have a number that's closer to 1, you are richer. If you have a number that's closer to 100, you are poorer. That's on a national scale. There's also a scale within every state, and that's basically the same thing, but it's a score out of 10. And so in order to actually calculate the ADI, as I said, you go onto the website, you plug in an address. This is the address for an apartment complex that's nearby. And when we put that in, you can see the state number for air deprivation index is 1. The national number is 12. Again, quite on the richer side, which this apartment complex is on the richer side of town here in Dallas. And so we compared 328 tether patients to over 3,000 spinal fusion patients. And this was pulling 11 different sites within the harm study group. When it came to the institutions, there wasn't really anything data-wise that stuck out that was interesting. But when it came to race, it was very interesting. There was a significant difference between race when it came to the proportions we saw for our VBT cohort and our fusion cohort. There was a much higher percentage of Black patients that got fusions versus VBTs. When it came to white patients, there was a much higher segment or proportion or frequency of white patients who got VBT versus who got fusions. And then the other category was were the many other races of kids that we treated. How about the most important question? When it came to the actual socioeconomic status, we found a stark difference, what we would say a very statistically significant difference. For the VBT patients, their average area deprivation index was 36.7. Again, when you look on this scale, that is very much closer towards the richer side of the area deprivation index. When you compare that to the fusion cohort, their average area deprivation index was 61. And you can see that is certainly closer to the right side of this scale, meaning more disadvantaged or poorer. And so I think it's important to understand that we don't know why there's this difference between access to care. It's not like we as surgeons are saying, oh, you look rich, you're going to get a tether. But clearly, we are failing at making this procedure as readily available when it maybe comes to knowledge. And I think more could be done to making this procedure, which again, allows patients to have much more flexibility, more readily accessible. And so I think there's much more work to be done on that, both from access as well as to dispelling many of these myths out there about VBT. Thank you.
Well, Jaysson, thanks. That's a great talk. It's very enlightening. I want to tell you, I'm one of the 53% with limited social media presence. So I think, but we've seen its effect over time, and I think you've done a lot of work in this area, right? We're limited on time a little bit, but just one question, how would you recommend that families, when they're utilizing social media, how can they get the best benefit from its use, right? So we're going to see a lot of advertising, you're going to see a lot of videos, but in terms of education and trying to, I think a lot of people do this, right? They want to do the best for their child. And what's your recommendation to families and the use of social media, and how can they use it to best benefit their child?
I think it's important to, understand that when we as physicians decide a treatment or kind of have a shared decision-making opportunity to decide whether we go fusion versus tether, that's very specific to that patient, their skeletal maturity, their age, whether their family has the means to deal with a second surgery. If the tether breaks, are they able, from a family standpoint, to deal with coming back to the hospital and dealing with that potential complication? And so it's a very specific decision. And so when you're on social media and someone's sharing their own experience, you don't know any of those details. And so I think you have to kind of come at it that this is someone's personal experience, and I can't apply everything to that when I'm making my own decision. And so as long as you take it kind of from that viewpoint, I think it's certainly safe, because we've seen from the data that families enjoy that emotional support when they hear the stories of other families that have gone through similar situations. But when it comes to the actual data, you can't rely on talking with kind of non-medical people when it comes to the actual research. That's when you got to speak with your physician. And when it comes to whether you should go fusion versus tether, like that has to be a final decision that you make with your surgeon.
Yeah, I agree. That's all great advice. So if we can move forward. Thanks a lot, Jaysson. Next up on the agenda, so Dr. Newton has been involved with tethering for a long time. He's been a big mentor for me, and he's here talking about combining fusion and tethering, so hybrid approach. And we've had quite a few questions coming up on the Q&A tonight about hybrid, so this should be a good talk.
Well, thank you so much, gang, for having me. The talks ahead have been just spectacular, and I hope that our audience can appreciate the level of sophistication they're trying to bring to you. I want to talk about the hybrid concept, and I have this titled "The Next New Indication for Vertebral Body Tethering." We'll see how it goes here. I do have some disclosures. These are companies that I have relationships with, both on the research and the development side. You've heard already that the tether can create 3D growth modulation, and I think this is a really important concept. How can we reshape those vertebrae over time using that device? And we have pretty good evidence that with the right amount of growth and the right indication, as you've been hearing, that this can be a very successful operation. But at the same time, you've heard that this cord can break, and the numbers are something like 50% at 3 years by several studies. And when that cord breaks, it's not doing its job anymore. If you finish your growth by the time that cord breaks, may not be a problem if you had lots of modulation. If you didn't, your curve may come back. We've also heard that if we get this done a little bit too straight and too young of a patient, we can get overcorrection, and that can be a problem as well. We also have some data to suggest that with time, this surgery seems to be less good over time. So the cumulative success drops the longer we watch. Now, again, I think we're all acknowledging that we're getting smarter with this, and we hope that we can bend that curve back up again as we get more experience. But one of those operations that has been really good for us has been a posterior spinal fusion. And I'm going to talk specifically about the selective thoracic fusion. And that implies that we selectively instrument and fuse one of the two curves. And so in some patients, the curve pattern is such that there's a thoracic top curve and a lumbar bottom curve. And you can see in this example where a fusion was done, not of both curves, but just of the top curve, we got a really nice correction of the bottom curve as well. And so we call that the selective thoracic fusion concept. It's a powerful technique, and it's really one of the options for many patients to compare to vertebral body tethering. So not all fusions have to be fusions of the entire spine. However, there are some in which that seems to be our best option, is a long fusion. And the question that we have come up with is, can we combine a posterior spinal fusion with the best of vertebral body tethering? And that combination, in most cases, is a posterior thoracic fusion, just as I showed you, because we know it can get immediate correction, and it's very reliable, just as you heard. And combine that with a lumbar tether where we can preserve lumbar motion where that motion counts the most. It's really the lumbar spine that we're trying to save as much flexibility and motion as possible. That's where most of the motion occurs. So in this curve pattern where we have a large thoracic and a large lumbar curve, can we avoid fusing from the top, very top to the very bottom? Will that selective thoracic fusion approach work here? Most of us, I think, feel that 59 degrees is just too big to count on a selective thoracic fusion to do the job. So even though the curve is flexible, that helps. But in this scenario, we're combining that very powerful thoracic fusion with the lumbar tether to help guide the growth of the lumbar and maintain and achieve and continue to gain correction using the tethering principle in that lumbar spine. Here's another example, nice curve. Again, where we fuse these and the levels and etc. are all things that your surgeon will debate with other surgeons, and we won't all agree on this call or this webinar which levels is the right levels to instrument. But we can get good correction, but on a big curve like that, standing up after this fusion won't be successful. And so adding that lumbar tether to put additional correction forces on that lumbar spine so that we can end up with at least maintaining the lumbar mobility, even if we can't maintain all the mobility. So some of these patients might have been candidates for a double tether, as Dr. Larson showed, but this is a way where we can get the reliability of the fusion for the thoracic curve and the benefit of the tether in the lumbar curve, which I think in some patients might be sort of the sweet spot if you want to think of it that way, as getting some reliability, but also maintain that lumbar flexibility. There are risks of this hybrid approach. The lumbar spine cord, the cord in the lumbar region tends to break earlier, and so failure of that cord can be problematic. Some have advocated using 2 cords. There's some pros and cons to that approach, but again, something to be discussed. And I have another concern, and that is that every patient who would have been a good candidate for selective thoracic fusion may also get a lumbar tether when the selective thoracic fusion would have worked alone. So that's, I think, a risk of this new procedure, and all new procedures have some risk of being overutilized. I think that's one of the risks here as well. And then, like vertebral body tethering in the thoracic spine or in the lumbar spine in isolation, use in patients with insufficient or no growth remaining will not lead to a long-term success, and that growth modulation unlikely to occur if you don't have enough growth to actually change the shape of those vertebrae for long-term success. So again, in a case like this, hybrid's not needed. We got 2 curves, but a selective thoracic fusion works beautifully. You could consider 2 tethers or a selective thoracic fusion. But in a case where that lumbar curve is a little bit bigger, did we spare a lumbar fusion or did we overuse a tether? I think that's going to take some more research for us to determine. But again, this is, I think, a nice combination of the 2 technologies that has a potential sweet spot for those patients with a double major curve. We classify these by the Lenke classification, but it's that curve pattern I just showed you, combining that very powerful 3-dimensional correction of the posterior spinal fusion, and then finishing the lumbar correction with a vertebral body tether and a growth modulation strategy for those that are still young enough. I think this has got some potential for us in the future, and so again, it may complicate the indications a little bit, but I think it's actually expanding some of the patients and improving the reliability. It's a newer technique. We're starting to get some 5-year data on, and I remain optimistic that this will be a nice way for us to improve our outcomes. Thanks. Hope that helps.
Great. Great job, Peter, like always. Just a quick question for you, for our audience. You know, some of the patients that you showed, you were actually fusing into the top of the lumbar spine. Can you just educate us on what your work has shown as you go lower down into the lumbar spine with respect to motion loss, i.e. when does it really become significant as you move down the lumbar spine?
Yeah, I think it's most significant when you start to get really L3 and L4 are where we really lose a lot of mobility. And it turns out it's very uncommon for us to stop a fusion at L2 just based on curve patterns. So we're commonly thinking about a selective thoracic fusion either to T12 or L1. And those, as I have done more of this, I would say that I'm fusing those selective thoracic fusions a little longer, because grabbing the very top of that lumbar curve and twisting it back underneath has been what's made for very powerful correction of the lumbar spine. Even though we're grabbing one of those lumbar vertebrae, we're still preserving the vast majority of the lumbar flexibility, which occurs in the lower half of the lumbar spine. Certainly, if we've got 2/3 of that lumbar motion, we've 2/3 of the lumbar motion segments is probably preserving 80 to 90% of the lumbar motion, because so much of it happens down low. So I think it's worth, again, probably hoping to improve the reliability by grabbing a little bit more of that spine, requiring the tether to do a little bit less work. And so that's been my strategy. I know that we all have slightly different approaches to how we do that hybrid approach, but both my selective thoracic fusions and my hybrid fusions have been getting longer as I get older.
We feel the same way. Grabbing the top of the lumbar spine functionally will have very little limitations for motion.
Yeah.
All right, everybody. Now we're really going to, these are spectacular talks from our surgeon participants. Now we're going to get into our patient stories, and we're very grateful and thankful, Amanda, for you joining us tonight, and look forward to you sharing your story after posterior spinal fusion.
Thank you so much for having me here tonight. Let me share my screen. Okay, so my name's Amanda, and I had scoliosis. So I was diagnosed when I was 8 years old. I was an active dancer and figure skater at the time. So my case was a little more complex. I also had a syringomyelia, which is a fluid-filled cyst in the spinal cord as well. And my surgeon, Dr. Scheffelbarger, who I still communicate with and work with today, did my surgery in 2017. I wore a Boston brace for 6 years for an average about 22 hours per day. So the time that I wasn't wearing it was when I was dancing or skating. And my family and I kept that very strict because we wanted to try to prevent surgery if possible. When I was about 12, we knew that I was going to have a spinal fusion. And at that time, the tethering wasn't FDA approved. So that's sort of why we went with the spinal fusion in this case. And I had my fusion in the summer of 2017. And as Dr. Newton said, here I do also have the selective thoracic fusion. So we stopped at L1. And this is sort of the before and after. So it was pretty rough. It was about a 70-degree curve each way. And I am doing really well now. It's about, I think, like 8 years post-op or so. I didn't have to have any physical therapy. And it was about 3 months until I felt significantly better with energy levels and, feeling like I could walk normally again. After my surgery, I didn't really do any physical activity too much again. I didn't really go back to dancing just because I didn't want to. I definitely could have. Now I've taken on running for whatever reason. So definitely can go back to those activities after the time is right. I really developed a strong interest in robotics and medicine. So I began shadowing my own surgeon, Dr. Scheffelbarger, who I work closely with. And I'm now a senior studying biomedical engineering at Boston University, hoping to be a spinal surgeon one day, which is a very full circle moment for me. These are some photos. And then the second slide here, I actually did some research at Boston Children's Hospital and at Boston University doing a lot of spine work. And I'm now working in neural dynamics at the med school at Boston University. And frequently when I go home to Florida, I do work with Dr. Scheffelbarger and talk to patients about this similar type of thing back in Florida. So that is my story. And from a physical standpoint, I would say there just is some stiffness in the upper portion of my back, but I don't think that really affects any day-to-day life, and you sort of get used to that feeling. But with the selective thoracic fusion, that was a really great decision. That definitely helped us.
Amanda, thank you. I mean, it's just a great story. Even without your surgery, I think you have a promising future ahead of you. One thing we've come across tonight, we've seen a few questions, or we've got some patients who are now in Medicast or their children around 5 or 6 years of age. with scoliosis when you're started. You know better than anyone in here, right? This is a long road. And if you had any advice to give to these families and their children, what would that be?
I think in the moment, sort of occupying yourself and keeping your mind busy is the best way to sort of forget that you're in a brace, for example. I remember I would always be involved in certain activities, and I think while it is uncomfortable at the start, wearing a brace and having to deal with all of those uncomfortable things, it really does become a part of you, and you do get used to it after a while. I remember a couple of months before my surgery when my surgeon told me I didn't have to wear my brace anymore. Falling asleep was difficult because I was so used to having that plastic under me. So it definitely becomes a part of you, and it definitely gets better from there. I remember it like it was yesterday, but it feels so far away. And I definitely came out on a great side, and it really inspired me to even pursue a career in this. So it does get better.
Yeah, and your story will help a lot of people. Thank you for sharing. Yeah. Okay, so up next, we're introducing Allie G. So Allie, as you saw, Amanda underwent a spinal fusion, is doing very well, and Allie underwent vertebral body tethering, and she's also here to tell her story tonight, so you get both sides of the story. So without further ado, I'll introduce Allie.
Hi, so I'm Allie. Let me share my screen. I am 21 years old and I had surgery this year. It'll be 10 years, but yeah, this is my story. So I was diagnosed in 2011. I was in the 3rd grade and I had a 30-degree curve. And this was discovered because I had just gone to the doctor because I was sick. And then when they were using the stethoscope, they found that my shoulder blades were uneven and sent me to get x-rays. And then we found out that I had scoliosis, but I didn't have any pain or any signs of scoliosis. So it was kind of like a shock. We did try 2 types of physical therapy from 2012 to 2013 before looking into surgery. I was in Greenville and Pennsylvania doing physical therapy. And then I also tried one type of bracing, which was the Scoliosis, and that was just when I would walk, I would wear it. And then I also did wear a hard brace from 2013 to 2014, a year before my surgery. And then when physical therapy wasn't really working anymore, we started to look at surgery. And we really only looked at VBT. We looked at 2 surgeons for that, but I did end up going with Dr. Samdani. I had surgery November 7th, 2014. I was 11 years old, and it was from T6 to L2, and I had it in Shriners in Philadelphia, and the recovery wasn't awful. I really didn't have any pain throughout this whole process of surgery. The only complications I had was with my medicine, and it was making me sick, so I couldn't really take it. But even with not taking it, I really was not in pain. After surgery, I was able to sit up, and I was walking the day after surgery, and then I had my surgery in November. December, I was back in school for half days, and then January I was back in school full time with no problems, able to sit the whole day and do all the activities. Like I said, I had no pain after my surgery, and I was back to all my normal activities within a few months. My life now, I have full mobility. I went through all of high school and middle school with no complications or pain. And then after high school, I went to cosmetology school for a year and a half, and now I am working in a salon. And I'm on my feet for 8 hours a day. And then I'm grateful to have been a candidate for VBT, and I wouldn't have wished for a better experience. It couldn't have gone any better than it did. And it was a big part of my life, but it also doesn't have a negative effect on any parts of my life, having to have this surgery or any activities I want to do. And I just want to say thank you to Dr. Samdani for doing this surgery on me and giving me a straight spine, and also setting scoliosis straight for giving me the opportunity to share my story. Yeah.
Wow. Thank you, Allie, for the kind words and for sharing your story with us. For, our patients and our participants that are considering a vertebral body tethering. And I know you and family were pretty intent on VBT, but do you have any advice on what they could do to try to make the right decision for themselves, or could do to prepare for the surgery, or what your experience or their experience after the surgery?
Well, I mean, for me and my family, we really like VBT was really the only option that we wanted to go with, unless we absolutely had to go with fusion. But I mean, preparing for it, like, I don't know, it just like I knew I had to have surgery, so I just like had to go with that. And then I mean, after, it wasn't hard for me. I do have a high pain tolerance. It wasn't hard for recovering, but I also think you have to remember that like you're going to be able to get through it, and you've already come so far and been able to like live with scoliosis, and you're just going to get through it and everything's going to be fine.
Great. Now, listen, a big, big thank you to both Allie and to Amanda. As you can see, one of our patient masters had a posterior spinal fusion, the other had a tether. Both had good results. It's just a shared decision and a very individual decision for each patient. So big, big thank you to both of you. I'm going to hand it off, Josh, who's got a couple more slides to go through.
So thanks again, everyone, for this evening. We really appreciate it. A big part of this is, as you know, scoliosis, Setting Scoliosis Straight is a non-for-profit organization. So these are free webinars, and we really plan to keep these going in the next few years. If you feel the need, kindly consider making a donation. You can do so by going to the Setting Scoliosis Straight website. You can text scoliosis to 41444, or if you're Jaysson Brooks and really good with social media and technology, you can scan the QR code here at the bottom. Next slide, please. Also, just newly released is the 4th edition of the Scoliosis Handbook. So there's updated information, including tethering, even how to take care of your scars and bandages. You can also visit the website or utilize the QR code here again on this screen. Next slide, please. And then we also have a YouTube channel. And so feel free to subscribe to the YouTube channel. All of the past recorded webinars can be found here. There are different educational videos, research publication videos, as well as patient stories and different FAQs. So this is just another avenue that Setting Scoliosis Straight has utilized to really provide information and updated objective information to patients and families. And then one last slide. So this is our final webinar of 2024. It's been successful enough that there's a 2025 lineup coming down the pike. So please feel free to continue to visit the Setting Scoliosis Straight website. And we're excited to continue delivering more information, and glad this has been helpful to a lot of patients and families, not only in the US, but around the world. We do have some survey questions, so this will help us improve our future webinars. So if you have a few minutes, please take the time to fill out the survey. And thank you, everyone. Speakers, Dr. Samdani, and all the families that are included tonight. We thank you for your time.